recorded? Oh,
Now it is.
thanks. All right. So, you know, in those situations where you can have a broken bone, but they're incredibly rare in our office because the pain is so severe with a broken bone that they never go to a chiropractor. They're just not, and they're not going to go to a naturopath. They're going to go to a medical doctor because they can't move. And you can smell these guys a mile away because they, you know, I have people walking in pain all the time in my office, but when someone has a broken bone, they move different than any other person. They are rigid, they won't breathe, they won't move. And so we're not going to deal with many broken bones. The only broken bones I deal with are friends who, I had a kid jam a finger in a basketball game and I x-rayed it for him. And yeah, he had a little avulsion fracture on his joint. And, but I do that for fun and it's way outside of my scope and it's not something I want to be liable for. So I do it for fun. I take a picture of it and I go, I'm not competent to deal with this. Go see an MD. And they do. So we just try and get rid of any, if I suspect a broken bone, I might x-ray it for them. If I suspect cancer in the bones, I might x-ray for them and I get rid of them. When I say get rid of them, I mean, I make sure they go immediately to a qualified medical doctor who's going to take care of their condition for them. Right? Any questions about that?
No.
Okay. Now, the next thing, the other source of pain is going to be like a pinched nerve or damage to the nervous system. And obviously there's 1,000 diseases that affect the nervous system. They almost never show up in our office. About 5 to 10% of our patients come in where they have some nerve root involvement where, and 99% of the time it's a bulging disc pushing, or there's some scar tissue pushing on a nerve. Yeah, sometimes you might get like a thoracic outlet syndrome or an impingement of a peripheral nerve. But for the most part, they come in because they have neck pain, back pain, or radiating numbness and tingling. And it's so easy to diagnose, again, a pinched nerve or a nerve problem because they're symptoms. They have radiating pain that travels. It's really easy. And if you're not sure, you do an orthopedic test and you can imitate the pain and provoke it, no problem. So we do deal with some of those. But the vast majority of people don't have bone problems. 5 to 10% might have a nerve root, but it's not because there's anything wrong with the nerve root. The problem is the bulging disc or the swelling from the facets, and usually a combination of both is pinching the nerve. Now, keep in mind as well, Chris, that the IVFs are huge compared to the nerves. You know, they're 10 times, the hole that nerve comes out is 10 times bigger than it needs to be because the body has a buffer zone. So if you're at a point where you have a pinched nerve, where you're getting the numbness, tingling, or pain radiating to the arms or legs or feet in a sciatica situation, rarely is this not a degenerative condition. In other words, that disc has to collapse, to bulge, and a big buildup of scar tissue and decay around the facets in order to squeeze the nerve to the point where they have radiating symptoms down their arm or leg. There's got to be a lot of swelling in the area to actually irritate the nerve root. And the nerve root doesn't have to be physically pinched. It can be chemically irritated as well by inflammation in the general area. But those, you're always thinking of degenerative disc disease, bulging disc, and arthritis if someone comes in, even if there was trauma involved in it. So, any questions about those? Okay. And then, so we've ruled out bone, nerve. The next one is it's either going to be disc, ligament. And now what I'm going to do when I talk about this is when we talk about the disc has two parts, the nucleus pulposus and the annulus fibrosus. The annular fibers of the disc are embedded in a cartilage matrix, but essentially the annular fibers are made of type 1 collagen, and they're identical in almost every way, shape, or form to a ligament. There's 70% type 1 collagen, a few other pieces of collagen mixed in there, but under a microscope and chemically in almost every way, shape, or form, they're ligaments. So when I talk about anything we do with the disc, disc healing and ligament healing are essentially identical, other than a little bit of cartilage in there as well, right? Any questions about that? Okay, so when I say ligament healing, I mean the disc. And then of course the nucleus pulposus is just a proteoglycan matrix. It's mostly water. It's more of a gel than it is water. And the primary purpose of the nucleus is it provides the strength, the compression strength in the spine. It's the nucleus that prevents the bones from collapsing. The only purpose of the annulus fibrosus is to hold the disc in place. It's essentially like a tire, but a tire has a little bit more spring and give to it because it has air, and the air in it. Remember, air is very compressible, and that's what gives you a little bit of shock absorption in the spine. Did you know the disc doesn't provide much shock absorption?
I thought it gave a lot.
It does not. And a guy studied this back in the 60s. Do you know what actually provides? There's two things in the spine that provide shock absorption. Number one is the S shape. The S shape provides the vast majority of it because it creates a giant spring. So if you hold your fingers like this and hit it, it starts to hurt really fast. If you bend your fingers, I can hit it as hard as I want, and the curve is absorbing the spring. So one of the things we're always checking for is alignment of the spine. If the spine has lost its normal S shape, the degenerative changes occur 10 to 20 times faster. So it's pretty critical that the spine maintains that S shape. And one of the big things we do in the office is if they have lost the lumbar lordosis or the cervical lordosis, we spend a lot of time rehabilitating that using exercises and stretches to reinforce that curve or to alter the shape of the spine. But the other thing, what actually provides all the shock absorption is the end plates. Remember the bone, the trabecular bone, the inside of you've got cortical bone all around the outside of the vertebra. The inside is trabecular bone, which is that lattice work. And that actually has some give to it. And the thick end plates, when you take, so this is what this dude did. I forget his name. I'll get you the study though, if you want to read more. It was really fascinating. So he took dead people and he would cut out a spinal unit, a bone, disc, and bone, and keep it all intact. And then he'd fill it with dye, and then he would put it in a vise and he would compress it. And as he compressed it, the goal was to see how much the disc could, what his question when doing all his research was, why do these discs bulge? What makes a disc bulge? Mechanically, what do I need to do to this disc to make it to rupture and fail? And what he found is as he compressed the disc, the gel would not compress, and gels don't. If you know anything about hydraulics, they're all based on the principle that oil doesn't compress at all, or very, it's like 0.01% will compress. And so what he saw, and it actually has pictures in the study, is the end plates would indent. And of course, the annulus fibrosus would bulge outward, but the nucleus would not. So as you compress it, the end plates are bulging inward, the disc bulges outward a little bit, but the gel in the middle itself did not, which is kind of interesting. And his research showed that what actually happened if you had like football players who hit other players, and ram their head, or you fall on your butt and compress the spine, it would actually fracture the end plate. Micro fractures of the end plate would occur before the disc would rupture. So in compression, he said almost universally, the bones break before the disc ruptures, which is pretty fascinating and eye-opening. And just kind of, this is just an FYI, but what they think actually happens in degenerative disc disease is you don't damage the disc, you actually fracture the end plates. And that's critical because even though the nucleus pulposus, which of course is holding the spine up, is doing all the work, it needs very little nutrition, but it does need nutrition. And the nutrition comes from the thick blood vessels, the bed of blood vessels in the end plate. So the end plate has a lot of blood vessels going to it, and these bring proteoglycans, which are the hydrophilic molecule that keeps water in the nucleus pulposus. When you run out of protein, these are giant molecules that are incredibly hydrophilic. And so as they break down over time, the body has to replace them. And I can only replace them through the blood vessels because the disc doesn't have its own blood supply. And so they go through the end plates. But when you fracture the end plates, they become thicker and thicker with the heavy cortical bone and prevent nutrition from getting to the disc. So eventually the gel in the middle dehydrates, allowing it to collapse, which results in bulging discs. I covered that really fast, but if you want to talk about it some more, we can. But that's what they think is the primary driver for degenerative disc disease. The other thing is that I don't cover that with patients, but the other thing is tearing and damage to the annular fibers. Results in scar tissue and degenerative changes as well. So we're paying attention to both. But the primary driver for degenerative disc disease, which is the most common condition we treat in our office, it's the result of enormous amounts of pain and problems, is trauma and mechanical changes to the disc. Okay?